Good morning, everyone. So I'll be talking about alcoholic hepatitis, hospital and beyond, going through a patient journey. I want to thank the event sponsors, Dr. Israeli and Dr. Muthasamy, for inviting me for the talk and asking me to follow Dr. Saab. So no easy feat. We'll dive right into a case. We'll talk about a 32-year-old female. She's presenting to an outside hospital and gets transferred here after a week of jaundice and abdominal distension. This is her first presentation to the hospital. She denies any prior history of liver disease, does endorse heavy alcohol use, drinks about 6 to 8 drinks daily, and stopped drinking a couple of weeks ago because she was not feeling well. She otherwise has no known medical comorbidities, no family history of liver disease, does have an IUD in place, but no other medications, including no over-the-counter medications. So an evaluation on her vitals, she's afebrile, she appears non-toxic, she's satting well on room air. On her labs, though, she does have significant leukocytosis. Her liver panel is abnormal. AST to ALT ratio is 2 to 1. Her prothrombin time is elevated. Her total bilirubin is markedly elevated at 18. Her renal function is abnormal, and her serum sodium is low. And on serologic workup, we see that viral workup studies essentially are negative, and imaging shows an enlarged liver with some mild splenomegaly without ascites. On exam, she's mentating well, she's deeply jaundiced, has some muscle wasting and enlarged liver. So all signs kind of pointing towards liver disease. So what are the next steps for these patients? So we'll go through that in today's talk about diagnosis, talk about prognosis for this patient, and spend a lot of time focusing on management. So here's a brief outline for the talk. So we'll dive right in. A big change over the last decade, really in the last 5 years, that have been added into the new publications is avoiding the term alcoholics. And we really substitute these terms out for all disorders, instead of calling a patient an alcoholic, really labeling them as a patient with alcohol use disorder and so on for all the other liver diseases. So the epidemiology, we're seeing a significant rise in alcohol-related liver disease, in particular in patients who are hospitalized, where alcohol-related liver disease tends to be the leading indication for patients who are hospitalized with chronic liver disease. Alcohol-related hepatitis accounts for about 1% of all inpatient hospitalizations, and over the last 2 decades, we've seen a significant rise, a near 28% rise over an 8-year period between 2007 and 2014. Follow-up studies continue to show ongoing rise. And what about mortality among these patients? It specifically is affecting young adults, but overall we've seen a rise in mortality over the last 2 decades. This is data from 1999 to 2016, and showing that young adults in particularly are vulnerable to this, with nearly tripling in their rate of mortality since 1999. Other highlights were females and then a rise in ethnic minorities. So how do these patients usually present? Symptoms may be nonspecific, but abdominal pain tends to be classic for most patients who are presenting with alcohol-related hepatitis. They'll often complain that they've not been feeling well. They may have fatigue as their key complaint. And in more advanced disease, they may also have some peripheral neuropathy, muscle wasting, loss in sexual drive, and amenorrhea. Physical exam is classic for jaundice in these patients. They'll often have right upper quadrant pain. They'll often mimic patients presenting with biliary disease, may even confuse providers to suggest that they may have cholecystitis. They may even have abdominal distension, depending on whether or not they have ascites. Labs, I mentioned this earlier, the AST to ALT ratio is often 2 to 1. Usually less than 10 times the upper limit of normal, somewhere less than 400. They're often jaundice. Total bilirubin is usually greater than 3. Alk-Phos is mildly elevated, and then they may or may not have leukocytosis along with prolonged prothrombin time. Imaging may show cirrhosis, may not show cirrhosis, usually will show hepatomegaly, and they may or may not have ascites. So how do we make the diagnosis? Again, in the last about 2 to 3 decades, we've moved away in general in pursuing liver biopsies among these patients. Liver biopsies were done very commonly back in the 80s and 90s. And this is from the most recent AASLD guidelines, again, advocating against pursuit for biopsies if the patients have classic presentation, as in jaundice onset has been recent or the last 2 months. They've had history of heavy alcohol use, may have recently stopped drinking or may not have stopped drinking, may have been drinking up until their presentation. Their liver panel is similar to what we just went over, and they lack confounding factors. They don't have a clear smoking gun for a drug-induced liver injury, they don't have other concomitant liver diseases, and they don't have any atypia within their labs. You can most likely say that these patients probably have alcohol-related hepatitis. To get a diagnosis of definite alcohol-related hepatitis, usually you need a liver biopsy, but in patients who have possible, as in they may have some confounding factors that may be confusing the picture, a biopsy may be pursued if needed. So coming back to our patient, she seems to fit criteria for a clinical diagnosis of probable alcohol-related hepatitis. She doesn't have any other underlying contributing causes. In addition to having alcohol-related hepatitis, we also know that she has an underlying diagnosis for alcohol use disorder. This is her first presentation, and no trial of steroids were initially given at the outside center. And regarding her alcohol use disorder, she's never tried rehab previously, no prior medical therapies, and appears to have good insight about her disease, is understanding and accepting that her disease, her presentation is due to her heavy alcohol use, and has very supportive caregivers. So how do these patients fare? So there are multiple prognostic scores that are available. Maddrey's discriminant function was among the earliest prognostic scores recommended. It's been around for nearly 4 decades. We have the most amount of experience with it, and it's a key criteria for a majority of studies that are conducted. A Maddrey's function greater than 32 used to carry a nearly 70% mortality rate over the last 6 months, or the next 6 months. More recent studies suggest that the mortality rate is probably lower in the range of high teens to maybe low 20s over 6 months. Next up is the original MELD score, so not the sodium MELD. Again, excellent for prognostication, specifically in patients who have MELD scores greater than 20. Glasgow alcohol hepatitis score is from UK and adds more specificity to the Maddrey's discriminant function when considering pursuit of steroids among patients. So the first 3 that I mentioned, and there are more that I haven't included here, are all fairly static scores that you tend to assess in patients' initial presentation, whereas Lilly's score is a more dynamic score and it helps assess for treatment response in patients who you've initiated steroids on. So in patients who have a good response are usually patients who have Lilly score less than 0.45 at day 7. There's a shorter Lilly score available for day 4 that isn't used as widely, but if needed, can be considered. So comparing these scores, this is a paper from last year looking at nearly 2,500 patients that were enrolled across 3 different continents. It's a global study, included 11 different countries and 83 centers. And when comparing all scores, MELD, the original MELD and the sodium MELD tend to actually do the best in predicting 90-day mortality among these patients, followed by Maddrey's and then the Glasgow alcohol hepatitis score. So you should really consider these patients, consider their MELD scores when considering, do these patients need just inpatient and outpatient management without a transplant evaluation, or should you be really referring these patients early on for liver transplant evaluations? So how about treatment? So we'll focus on inpatient treatment first, and then I'll come back to outpatient treatment in a little bit. The inpatient treatment for alcohol-related hepatitis should start first by assessing whether these patients have any underlying infections, because these patients are at high risk for infections, and infections usually increase their mortality rather significantly. In addition to considering infections, you should also consider for symptom control. So a lot of these patients will be complaining of abdominal pain, may have a lot of nausea, and may even have some vomiting, so controlling those, and if they develop ascites or hepatic encephalopathy, controlling them. So more specifically for alcohol-related hepatitis, prednisolone has been around for the last 30 years, and there are probably greater than 20 plus randomized control trials reviewing prednisolone. It's very important to assess contraindications among patients when considering prednisolone. Make sure that they're not infected, make sure that their renal injury is responding to treatment. If it's non-responsive to treatment, you should not consider prednisolone. Make sure that they're not progressing to multisystem organ failure, don't have any concomitant liver diseases, and don't have underlying GI bleeding. So the biggest trial, the STOPA trial, assessing prednisolone versus no prednisolone, unfortunately didn't meet its primary endpoint, but on post hoc analysis, so for patients or for providers who are advocates for prednisolone, the post hoc analysis was key. When adjusting for prognostic variables, it did show short-term 28-day mortality benefit. And in general, if patients don't have any key contraindications, it's probably reasonable to consider prednisolone followed by a Lilly score to make sure that they are good responders. If they're not good responders, you should consider stopping it. So what else can we offer aside from prednisolone? Nutrition is actually key, and there are multiple studies showing patients who take low-calorie diets actually do very poorly. Low-calorie cutoff is actually less than 21 kilocalories per day based on their body weight. The recommendations from both societies, European and American, are that you should consider at least a 35 kilocalorie diet in these patients early on. So aside from nutrition and prednisolone, NAC has actually gained a lot of popularity in the last decade. Most of the studies are from Europe, from French groups, where they've co-administered N-acetylcysteine along with prednisolone in these patients, and there have been very promising results with reduced infection rates and decreased renal injuries in these patients. But further evaluation is needed. I usually do consider NAC if I'm starting prednisolone in these patients. All the other treatment options that are available really haven't been very promising. Pentoxifylline in early studies did show significant reduction in short-term mortality and protection against HRS, but follow-up studies unfortunately have not continued to show this. So how did our patient do during her hospital course? We'll actually split the scenarios into two here. So in scenario one, she actually does not respond to volume expansion. Her renal insufficiency continues to worsen. So she undergoes a liver transplant evaluation. During the liver transplant evaluation process, she develops new ascites, new HE, goes on to developing a variceal bleed, gets intubated, goes into the ICU, successfully gets treated and banded, and is extubated. But in scenario two, actually our patient did really well. Her renal injury responds to volume expansion, and steroids are initiated in the patient. In this scenario, she also develops ascites and hepatic encephalopathy, but no variceal bleeding, and we're able to control both of these complications medically. And because she's developed further decompensations, she also undergoes a liver transplant evaluation. However, compared to scenario one, she's actually doing far better. She's tolerating a good diet, and her symptoms are actually improving, and discharge planning is being made. So how do patients in scenario one do where liver transplantation is being considered? So a brief mention of the 6-month rule. It was born out of less from evidence-based guidelines, but more from suggestions at the NIH that maybe we should advocate for longer periods of sobriety before pursuing transplantation in this, which the financial payers grabbed onto and implemented a near 6 to 12-month wait times in early 1990s. And slowly, multiple centers started adopting this policy of a 6-month wait time rule. And the advocates for the 6-month wait time rule back in the 1990s really did so by saying that this period of abstinence really would help establish a foundation for the patient to attend rehab, plan for post-transplant sobriety, and commit to a treatment plan. And then also, in the meantime, provide providers with a time frame to assess and see which patients are more likely to spontaneously recover versus which patients are more likely to not recover and truly need transplantation. And in the last 10, 13 years or so, multiple studies have shown that really early transplantation actually provides good outcomes, but more importantly, shows that these patients really don't tend to relapse significantly. So the expected relapse rate among patients who are transplanted back from the 6-month wait time rules are around 20 to 40%, and the percentage is variable depending on how we define relapse. Whether we include all relapses, then the relapse rates may go as high as 40%, where patients may have slipped and gone back to being sober, versus if you include patients who are drinking heavily, their relapse rates tend to be a little under 20%. And in these are multiple studies, US-based studies showing that, single-center studies showing that the relapse rates for most of these patients were well under 24%, including for harmful drinking. And the follow-ups on some of these studies has been as far out as 3 years. So really, we moved away from needing 6-month wait times, really a wait time period, but looking more at other factors when considering patients for post-liver transplant sobriety. So what are some of the other factors that we look through? There's a list is long, so we make sure that these patients have good support systems, make sure that they haven't had multiple relapses in the past, haven't failed prior rehab, assess their insight to making sure that we talk to our patients before they get encephalopathic, before they get intubated, and they don't have multiple other substance use disorders in addition to their alcohol use. Non-compliance is another key one, to making sure that they're staying compliant previously prior to their presentation, and then the family history of alcohol use disorder along with comorbid mental health disorders. So what about spontaneous recovery? The second point the providers had made back in the 1990s on following the 6-month rule. There are studies from the Accelerate Data Group, which is a consortium of 7 different centers studying early transplantation for alcohol-related hepatitis that showed significant mortality benefit. But this single center study included about 140 patients from 2012 to 2018 and recruited all patients who presented with less than 90 days of sobriety, underwent a liver transplant evaluation, and specifically had a high MELD score greater than 25, and showed that really patients who underwent liver transplantation were a small fraction, about 34% of them, but among the remaining 66%, 42% of the patients did not recover, and 24% who did recover without liver transplantation really did not go back to being compensated as expected. So waiting on these patients is really not recommended. What were some of the factors that they assessed that highlighted that patients did poorly if you're waiting for preventing transplantation is if the patients were older, they were less likely to do well, and patients who had a high peak MELD were less likely to do well. So patients with MELD scores greater than 34 and older patients greater than 44 years of age should really undergo a liver transplant evaluation and get transplanted if they're good candidates. And then let's come back to our case. So in scenario 1, the patient actually gets listed because she did have good insight, had good social support. This is her first presentation. And on day 21 of her transplant hospitalization, she peaks at a MELD score of 40 and ends up getting a liver transplant evaluation and does fairly well after transplantation. So in scenario 2, our patient's MELD score peaked at about 29. Her Lilly score was actually favorable, so she continued use of steroids and did very well as we had previously noted. So she ended up getting discharged with close hepatology follow-up. So how do we manage these patients who are getting discharged after after a recent hospitalization with alcohol-related hepatitis? Unfortunately, we don't have great guidelines on managing these patients. They tend to be very sick. With rising rates, we are seeing more and more of these patients show up to our clinic. So it's important to differentiate between short-term versus long-term outcomes. The short-term outcomes for these patients tend to be primarily dictated by how sick they were at their initial presentations. It tends to be dictated based on their liver decompensations. But if they're alive at the 6-month mark, this study noted that their long-term outcomes tend to focus a lot more on whether or not they go back to drinking. So in this particular study, they assessed sobriety among these patients, and patients who relapsed within the first 6 months, based on their peak MELD score, based on their decompensations, did just as well as patients who did not relapse but had similar liver decompensations. However, past the 6-month mark, relapse did play a big role. And the study really did advocate for maybe considering alcohol use disorder management in patients who do make it to the 6-month mark. I'm going to actually suggest that we should probably start implementing abstinence early on in these patients. But what do we do in the short-term care while we're implementing abstinence in these patients? So they are fairly sick, so they do require very close follow-up. Most of these patients I tend to see every 2 weeks, every 4 weeks, depending on their decompensations. I do tend to do a lot of frequent labs on them. They're still at high risk for infections, so I do ask them to call each time if they have any issues. Nutrition is another key factor among these patients. I get nutrition involved early to make sure that not only are they meeting their calorie goal, but we're also assessing micro and macronutrient deficiencies, which tend to be very common among these patients, and then monitor for infections like I mentioned earlier. So among the hepatic decompensations, in their ascites management, I'm more cautious compared to another patient with cirrhosis from a different etiology like NASH or Hep C or Hep B, who he or she may be presenting early on with recent ascites development. I'm fairly aggressive in those patients in titrating their diuretics up, but among alcohol-related hepatitis patients, I tend to be very slow in titrating their diuretics up. I tend to keep bringing them back each time I titrate their diuretics up, keep a close eye on their kidney function because they're at higher risk for developing renal injuries. Variceal management is probably similar to other patients with cirrhosis. There's no good timeline on when to possibly consider doing endoscopy in these patients. I usually tend to delay endoscopy, ideally 3 to 6 months after their discharge. And encephalopathy management, again, is identical to other cirrhosis patients. I'm getting there. Alcohol use disorder management. So important to start referring these patients out early to addiction medicine providers, to behavioral medicine providers. If they have other mental health comorbidities, send them to psychiatrists. Do not delay initiation of alcohol use disorder management. All patients are not the same when it comes to alcohol use disorder treatments. So one suggestion that may work for one patient may not work very well for another patient, such as, AAs are very commonly recommended by most providers, but not all patients tend to be social. They may not feel comfortable talking in a big setting and may benefit from individual therapy. So some consideration needs to be done, and we're probably not experts at it to do this, so we do need our help from the addiction providers. What about long-term care? So long-term care, a key component from the liver standpoint tends to be on fibrosis assessments to see if these patients do have underlying cirrhosis. Most histologic studies that have looked at post-transplant outcomes have shown that majority of our patients who get transplanted do tend to have cirrhosis on their explant. Data shows that up to 90, maybe even higher percentage of patients do tend to have cirrhosis. So most of these patients who are presenting with severe alcohol-related hepatitis do have underlying cirrhosis, but patients are still curious, especially the patients who are getting better, in whom the hepatic decompensations are resolving, are interested to know whether they need to keep seeing providers long-term. In those patients, I usually recommend doing FibroScan. MR elastography hasn't been as well studied in alcohol-related hepatitis, but depending on how far out you tend to do these, maybe if you're doing them about a year out, it's probably reasonable and can be extrapolated to other liver disease etiologies. And then I kind of already mentioned alcohol use disorder management, so very important to involve behavioral medicine, user assistance and co-management, because really we lack the expertise needed in managing alcohol use disorder for these patients. And they often will consider pharmacotherapy, but maybe hesitant early on in the disease. This is where hepatology input is valuable in considering medications like naltrexone, which used to have a black box warning, but no longer does. So coming back to our case, after discharge in scenario 2, the patient actually did end up starting a camprosate and went to see addiction medicine. Within 2 months, started getting bi-monthly paracentesis. The addiction medicine provider switched her acamprosate to naltrexone as her liver disease was improving. She started seeing a therapist and a psychiatrist for a general anxiety disorder. And about 9 to 12 months later, she continued to remain sober, was off naltrexone, and was doing fairly well. Her MELD had improved, but her hepatic decompensations hadn't resolved. She was still needing ascites. So in summary, alcohol use and alcohol-associated liver disease is on the rise. Patients with alcohol-related liver disease really have 2 underlying disorders. Important to attack both those disorders when you're managing these patients. And the treatment really starts with abstinence and addressing the alcohol use disorder. Decision of transplant candidacy is best decided at a transplant center, and there's a growing acceptance of early transplantation for alcohol-related hepatitis, so we are no longer waiting on 6 months to consider evaluating these patients. And outpatient care in recently discharged alcohol-related hepatitis patients should focus on their hepatic decompensation in the short term and then their alcohol use disease management in the long term. Thanks.